I'll also mute myself for now.
You are live, you can start.
So very good evening to all. On behalf of Sun Pharma, once again, I take this opportunity to welcome our all eminent speakers and all my delegates. Pharmacare division of Sun Pharma, as you know, is the face of ear, nose and throat medical fraternity of Sun Pharma. Welcome in ENT ISA Classrooms 6 series, a joint venture with Sun Pharma. Today, to start with, we have our eminent speaker, Dr. Vijaya Krishnan, followed by Dr. Srinivas Kishore, followed by Dr. Roshan. And today's sessions will be moderated by Dr. Seemab Sheikh. Over to you, Dr. Seemab. Welcome.
Thank you, Mr. Sahai. And at the outset, a big thank you to Mr. Sahai, Mr. Mahindra, Mr. Juneja, and the Pharma division of Sun Pharma to keep supporting us with these academic events. And like we were talking some time back, it's really become the talk of the town. So today we are here. Welcome to all the viewers on a Sunday evening. We're back here again to get classroom, and we're here to discuss the part of OSA which is in the pediatric section, which is something which is very important. We'll have 3 speakers with us, and what has happened is in the earlier years, pediatric OSA was really not pediatric OSA. It was all about the concept of just a tonsillectomy and an adenoidectomy. So we would do a tonsillectomy and adenoidectomy, and that was the end and be all of OSA. Until such time as we all started realizing that it's really not that simple. There are lots of things in pediatric OSA which we are really not looking into very carefully. And then once we even diagnose that very carefully, we are probably still landing up with a lot of residual problems with pediatric OSA. So that's how the entire shift went. So first we got into the detailed depths of pediatric OSA, which was different. We still operated, we still had a lot of issues. And then after the residual OSA, we also all landed up trying and understanding that it was probably not restricted just to the ENTs. So there was a lot of the maxillofacial, a lot of the dental fraternity that also needed to be involved in pediatric OSA. So today's session of ours is going to comprise exactly that. We are going to go in that same format. We have 3 speakers with us, very well known to all of us. I will introduce them each one as they come. The first one will be Dr. Vijaya Krishnan. Second will be followed by Srinivas Kishore. So Vijay will talk to us about everything about the present concepts of pediatric OSA, the current concepts, which will then be followed up with Srinivas, who will talk to us about exactly what I said, how pediatric OSA was still having so much of residual issues. And then after that, we will still go back onto the dental fraternity, where Dr. Roshan Ryan is with us, who will talk to us about the management from the dental fraternity point of view. So without much ado, I will ask Dr. Vijay Krishnan. Vijay Krishnan is actually the face of our ISSA, not only in India and in a lot of other places. I'll be proud to say that his journey has been with us for almost 13 years, since the time I've actually seen him graduate and come forward. And he is academically and otherwise so brilliantly placed in the field of our ASSA and OSA that nobody better to tell us today about current concepts of OSAS in children. Vijay is from MERF in Chennai. We all know that. So I would like to hand it over to him for him to give us what the current concepts in pediatric OSA is all about. Over to you, Vijay.
Good evening, one and all. On this Sunday evening, I welcome you all for this IASSA Classroom Webinar Series 6 to discuss about current concepts in the management of pediatric OSAS. It is incomplete without this slide when we talk about pediatric OSA. If you look back in 1837, Charles Dickens characterized a red-faced fat boy in a state of somnolency, who is the servant of Mr. Waddell's Joe in this posthumous paper of Pickwick Club, from which the Pickwickian syndrome name came off. In 1888, Professor Guy from Amsterdam explained a terminology called aproxexia, which is an abnormal inability to pay attention in patients with acute and chronic nasal infection. Basically, he was trying to explain that adenotonsillar hypertrophy or a nasal obstruction causes hypoxia, which causes inattention. Later in 1906, Sir William Osler used the term Pickwickian to describe hypersomnolency with morbidly obese patients. Almost after 5 decades later, Bickelman and his colleagues described and popularized the term Pickwickian syndrome. Later in 1965, Menashe and associates described 2 non-obese children with adenotonsillar hypertrophy and cardiovascular changes who were treated successfully with adenotonsillectomy. In the modern medical literature, our beloved Professor Christian Gulimilnalt, who is no more, who is the father of sleep medicine, reported the first series of pediatric OSA in 1976. Around 1980, Professor Colin Sullivan, who invented the CPAP, we all know, he applied CPAP in a 13-year-old boy in his first series of 5 patients, out of which 1 patient was an age of 13-year-old boy. So let us come to what is pediatric OSAs. So that is apnea, which is cessation of airflow at the nostril and mouth for at least 2 breaths in the presence of continuous breathing effort. This is called obstructive apnea. Here, it is considered as 2 breaths instead of 10 seconds in adult OSAs. Hypopnea is reduction in tidal volume, that is 50% reduction in airflow associated with either arousal or more than or equal to 3% desaturation. Only if you do type 1 PSG, you will be able to get the data about arousal. So otherwise, we can even consider association with 3% desaturation in the presence of continuous respiratory effort. So apnea-hypopnea index is number of apneas and hypopneas per hour of sleep. So these are the few terminology which you have to remember, like obstructive sleep apnea. These all we have discussed in the previous class. So obstructive apnea is, there is cessation of airflow. There is no, in the presence of respiratory effort. Central apnea is no airflow, no effort. Mixed apnea, no airflow. There is initial central apnea followed by obstructive apnea. That is called mixed apnea. Katz and Marcus categorize the severity of OSAs according to AHI. So less than 1 is considered normal, 1 to 4 is mild, 5 to 10 is moderate, and more than 10 is considered severe OSA. Almost 10 to 12% of pediatric population has primary snoring, of which 1 to 3% is considered as OSA, diagnosed as OSA, though it is underdiagnosed because we don't do PSG in all the children. And the recent literature clearly says it is not just 3%, it is almost double the value, it's around 6%. The peak incidence is among preschoolers because of the adenotonsillar hypertrophy, the size which is larger than its relation to the upper airway. And almost 20 to 30% of children with snoring have OSAs. And the risk of OSA increases by 12% for each increase of 1 kilogram per meter square of BMI above the mean. So if you look into it, the various future factors responsible for sleep apnea, most of them will can be attributed to the genetics, which is from the parents. Obesity, complex upper airway anatomy, that's the length of the cranial base and the angle, retroposition maxilla mandible, facial features, tongue and lateral pharyngeal wall volume, reduced ventilated drive and it responds to hypoxia. See, all these you have to keep in mind when we are planning or when we are treating a child with obstructive sleep apnea. These may be unknown reason for the failures of adenotonsillectomy. And epsilon-4 allele of the apolipoprotein E gene is main reason for obesity. So we all know that children are obligate nasal breathers. So decreased caliber of the airway caused by nasal obstruction plays a major role in pediatric OSAs. And the soft tissue, the tissues, laryngeal soft tissues and the pharyngeal muscles are very compliant, and it is complicated further by diminished muscle tone, which happens during sleep. So all this compromised skeletal anatomy, neuromuscular compromise plays a vital role in the pathophysiology of pediatric OSAs. So children with OSA have high peak rate than control subjects, and children with habitual snoring peak rate correlates with the severity of OSA. More the severity, more the peak rate. And peak rate decreases tremendously after adenotonsillectomy. So as I told you, the nasal resistance plays a major role, and we can clearly see that the improvement in OSA after reducing the turbinate hypertrophy or a septal correction or administration of intranasal corticosteroid or rapid maxillary expansion. These kind of procedures clearly says that there is an improvement in OSA that is because of increased reduced upper airway resistance because of all these procedures. So, and the next common contribution is to the skeletal abnormality because it is a growing phase. Children with craniofacial dysmorphology, the contribution of skeletal abnormality to the development of OSA, all are important factors when we are seeing. Usually these children will be having a mouth breather. So when they keep the mandible lower, that influence the dentoalveolar morphology and the facial growth, resulting in high arched palate, narrow maxilla, retrognathia, that causes the long face syndrome. And following adenotonsillectomy in these children, there is a resolution of both open bite and cross bite, which can be observed within 2 years, and sometimes even resolution of mandible and maxillary inclination abnormality within 5 years after adenotonsillectomy. So there are 3 distinct types of pediatric OSAS. Like type 1 is associated with marked lymphadenal hypertrophy. Type 2 is mainly with obesity, and type 3 is children with variety of craniofacial and neuromuscular disorders. There are similar symptoms and signs in both type 1 and type 2. It's like habitual snoring, disturbed sleep, diaphoresis, bedwetting, night terrors and nightmares, choking or breathing pauses, nasal speech patterns, mouth breathing, frequent visits to primary physician because of recurrent respiratory tract infection, and retrognathia and midfacial hypoplasia, etc. But the important factors, the important differences if you see between type 1 and type 2 is hyperactive behavior, attention problem, enlarged tonsils and adenoids, recurrent otitis media. These are all very common with type 1 OSA. In type 2 OSA, there is associated excessive daytime sleepiness, which is contrary to our pediatric OSA. Usually they will be hyperactive. But in type 2, they can be excessive daytime sleepiness. And if you see here, a lot of systemic issues like left ventricular hypertrophy, systemic hypertension, insulin resistance, serum lipid abnormalities, elevated C-reactive protein, elevated liver enzymes. So OSA type 2 is almost like a metabolic syndrome affecting the entire body. And we all know that obesity and OSA is a complex mechanism, and it is a vicious cycle. Obesity causes OSAS and OSAS causes obesity. So if you look at the long term, what can happen in this age group, if there can be a failure to thrive, that is growth failure because of insulin-like growth factor deficiency, and cardiovascular consequences like pulmonary hypertension, systemic hypertension because of this hypoxia, hypercapnia, and neurocognitive consequences like poor scholastic performance, learning disabilities, behavior problems, aggressive attitude, hyperactivity, and poor attention span. All this can be seen in children with OSA. So if you examine these patients, usually they may be type 1 will be underweight or type 2 will be overweight. There will be adenotonsillar hypertrophy, typical adenoidal phases, micrognathia or high arched palate, failure to thrive, and sometimes even hypertension may be there. And tonsil, usually we grade with Friedman's grading, not going to go in detail. So after the complete clinical examination, we would be proceeding further to investigations. So level 1 PSG is the gold standard. Even in pediatric OSAS, level 1 is considered as gold standard. And we want to know where the obstruction. So simple X-ray nasopharynx will tell us whether there is any obstruction in the nasopharynx, like adenoidal hypertrophy, where we can grade from 1 to 4 according to the airway. So PSG is used to diagnose or rule out many types of sleep disorders. It's not just for OSA. So other kind of sleep disorders are also common in pediatric age group. If you ask me what are the indications of PSG in children, there is a big list. And one of this is OSA. But if you ask me, is there any specific conditions where you have to do PSG in patients coming with snoring and sleep apnea? Yes, especially in patients with syndromic children or less than 3 years, or with neurological or cardiovascular compromise or coagulation abnormality, unreliable parent or caregiver history. And the history and physical examination do not correlate. They may be saying it is very severe, and if you look inside, there is not much of adenotonsil hypertrophy. So when there is a surgical treatment failure or child with morbid obesity, so these are the places where you may have to stress to do PSG in this situation. And you should have a child-friendly laboratory for a cooperation, and we'll be looking at the sleep pattern. We will be monitoring the sleep waves, and we'll be monitoring the respiratory system with nasal and abdominal and chest movement with nasal and oral airflow, and we'll be monitoring the cardiac function by pulse oximetry and heart rate, and body position and leg movements will also be measured in this. If polysomnogram is not available, even audio taping or video taping, overnight oximetry or nap polysomnography or unattended home polysomnography are acceptable in this age group. What else we can do with PSG, especially in pediatric age group, is capnometry is extremely useful, especially in children with chronic lung disease, those receiving ventilatory support. We can measure end-tidal PCO2 or transcutaneous PCO2, because these children with the hypoventilation will be having carbon dioxide retention. If you're, and there will be hypoxia and oxygen desaturation. If you are going to just give oxygen, the carbon dioxide will be building up, and finally the patient will, the suffering will be continuing. So PCO2 measurement in polysomnogram is very important, especially in infants and neonates. So this is actually a child and a couple of the type 3 OSAS children undergoing a sleep study. This is an MRI picture showing the air column behind the palate and tongue base. Here you can see the adenoid which is blocking the airway, and palatine tonsils which is blocking the airway. This is a dynamic MRI of a syndromic child showing a huge adenoid which is blocking the airway, and you can see a small tongue and retropositioned mandible. This is a dynamic MRI of a syndromic child showing a huge adenoid which is blocking the airway, and you can see a small tongue and retropositioned mandible. This is a dynamic MRI of a syndromic child showing a huge adenoid which is blocking the airway, and you can see a small tongue and retropositioned mandible. I think there is a feedback. Somebody is so when we need further treatment, which patient needs further treatment? So we categorize as major and minor criteria. So presence of 5 major criteria or any of the 3 major with 3 minor criteria should reliably indicate the presence of OSA that requires further treatment. So like OSA, apnea-hypopnea index of more than 2, or respiratory arousal index of more than 2, or oxygen saturation less than 90%, or with excessive daytime sleepiness. So these are all the parameters which we consider most significant. So they have been named major criteria. And some blood reports like C-reactive protein, HDL, LDL, fasting insulin, elevated non-epinephrine creatinine ratio, adenotonsil hypertrophy of just grade 1. So all these are considered as minor criteria. So according to this, we can suggest whether the child needs further management or not. So if you look into the treatment option, lifestyle modification plays a major role, especially in type 2 OSAS and oral appliances, CPAP, surgeries. So in the protocol, the treatment protocol, when a child comes with the snoring, suggest sleep study. After clinical examination and evaluation, do a sleep study. If it is normal, follow it up. If it is positive, refer to a pediatric pulmonologist or an ENT and choose a conservative surgical treatment, or you can give a medical therapy. If the patient is not willing, you can give a medical therapy, CPAP, oxygen, or weight loss. And if there is a compromised skeletal anomaly, you can do a skeletal deformity. You can plan for skeletal expansion. If any of this fails, then also the other option is skeletal expansion and soft tissue reduction of all affected sites, possible sites. And if it is failed, re-evaluation, re-operation, or tracheostomy, which may be the ultimate, or if it is success, follow it up. So the next thing, common thing is CPAP or BiPAP, which delivers a continuous flow of air and provides a pneumatic splint to the upper airway during inspiration. This is a child actually referred to us with a primary pulmonary hypertension who was comfortably sleeping with a CPAP. So with proper counseling and behavioral therapy, even the pediatric age group can be treated with CPAP. The indications, if you ask me, the surgical contraindications or that there is any delay in surgery or unresolved OSAs after surgery, CPAP or BiPAP is the choice. So the CPAP promotes weight loss, suppresses leptin secretion and acid reflux, improves cardiac function, and decreases the airway hyperresponsiveness. And CPAP is safe and effective in an attended environment. You should not leave it alone. Still, the compliance rate is around 50 to 60% as like an adult compliance rate. It has its own difficulty in wearing, skin breakdown, nasal congestion. But the most important factor is mid-face hypoplasia because of the pressure by the mask. So we have to constantly evaluate them about the facial bone growth. Medical management of adenotonsillar hypertrophy, the recommendation is azithromycin, 12 milligram per kilogram once daily for 5 days, followed by 5 days drug-free interval of 4 cycles to be done. Or you can give 12 milligram per kilogram once daily, twice a week for 12 weeks. Can be combined with intranasal corticosteroids like fluticasone or mometasone, nasal spray, twice daily for 1 week, followed by once daily for 3 months. Along with montelukast or leukotriene receptor antagonist can be given according to the age. In certain situations, antihistamines and nasal decongestions may be applied. Surgical management, adenotonsillectomy is the primary treatment modality. Almost more than, it gives success rate of almost 85 to 90%. Especially it is, I'm not going to go in detail about adenotonsillectomy. We had a wonderful session by Dr. Naveen Patel in the first class. So it definitely gives significant benefit in type 1 non-obese pediatric OSA. But in type 2 obese pediatric OSA, it often comes with a residual OSA. But there will be a significant benefit on the glycemic control and other parameters. Most important thing to understand in pediatric OSAs who are undergoing adenotonsillectomy is high-risk patients. That is, they can come back with respiratory complications, especially child less than 3 years of age if you are going to do adenotonsillectomy, or child with severe OSAs with cardiac complications, or less than 15 kg, failure to thrive, or obese children, or craniofacial anomalies, or neuromuscular disorders, or those with current respiratory infection. You have to be very careful in choosing these patients for surgery. Especially, you may have to you should not be doing these patients as a daycare procedure, and you have to admit them overnight and discharge them once they are comfortable and fit for discharge. So if adenotonsillectomy fails, other surgical modalities like genioglosal advancement, maxillomandibular advancement in adolescents, or higher suspension, labioglossopexy, especially in neonates or a newborn where there is a tongue-based collapse, or even tracheotomy for severe or refractory cases. Especially in type 3 OSAS, close follow-up is very much essential, as there can be ongoing sleep disorder breathing even after the primary treatment. So rapid maxillary expansion, if the child with maxillary contraction, will be dealt in detail by Professor Ocean Ryan. And distraction osteogenesis in adolescent age group, where you can't, when already the palatal sutures, everything has happened, or you can advance 2 or more bony segments slowly, 1 millimeter per day, and the gap will be filled within 4 to 10 weeks. Myofunctional therapy plays a major role, especially in residual OSA, and it will be discussed in detail by Dr. Srinivas Kishore in his further talk. So tracheostomy, it bypasses the airway obstruction. If you ask me one surgery which can which we can't say 100%, 99% curative will be tracheostomy. It bypasses the airway obstruction. It is indicated mainly in severe OSAs with low oxygen saturation below 60% or with cardiac arrhythmias, those who are not fit for major surgery. It has its own complications in pediatric age, so that we have to keep in mind. So the post-op evaluation is very important, especially we have to reassess all the patients with pediatric OSS after the primary treatment, whether there is any further treatment is required or not. So the clinical reassessment will be done usually after 6 to 8 weeks. In 12 weeks time, we can even repeat PSG to check whether the child is completely out of OSA or not. So objective testing is recommended in children with persistence of symptoms. So surgical failure, if there is any persistence of symptom, that child has to be further evaluated with sleep endoscopy or diagnostic imaging, which will be discussed by Dr. Srinivas Kishore. So to come to last few slides, so this is a protocol where a child comes to you with snoring during health supervision visit, usually which happens in the school. You have to evaluate them with complete history and physical examination. And if both is suggestive of OSA, then proceed with further evaluation. If it is not suggestive of any of these history and clinical examination, then you have to follow up the patient with health care supervision. So the next question, when the child has typical history and clinical sign, the second question you have to ask is whether it is a high-risk patient or not. So these are all the high-risk patients. So if the patient is a high risk, refer to a specialist who is dealing with these patients. Now, if they are not a high-risk patient, then the third question you have to check is whether the patient is having any cardiac or respiratory failure. If there is any of these symptoms or signs, refer to the particular specialist. If no, then further evaluate this child with PSG or other studies as I discussed earlier. Both, if says yes, proceed for further management. If the study is inconclusive, if other study is inconclusive or negative, do PSG. If the study is positive for OSA, then proceed for further management. So the further management is, as I told you, the first, if the candidate is for adenotonsillectomy, yes, proceed with surgery and following them. If the candidate is not for adenotonsillectomy, look for other treatment options like CPAP, appliances, weight loss, or consider opinion from a sleep specialist. If the child improves, follow them up and keep in regular follow. So to conclude, snoring is unlikely to be normal in a child. That's an important point. So pathological sleep or disorder breathing occurs in almost 10% of the pediatric population. So there are important similarities and differences between adult and children. Sleep disorder breathing can cause neurobehavioral and cardiac complications, so it is not to be ignored. Adenotonsillectomy is still the first line of management and cures about 90% of children. In the T&A algorithm for treating patients with severe OSA, special or high-risk patient populations are still being optimized and has to be taken under care. Syndromic children and those with neuromuscular disease pose a significant management challenge and need a multidisciplinary approach. That's what we are trying to. So orthodontic treatments like rapid maxillary expansion improves or prevents sleep disorder breathing by enlarging the nasal passage or airway. Thank you.
Thank you, Vijay. That was really wonderfully well elucidated and a very comprehensive way of bringing it out. I think all those ENTs who've been listening to you should have had their antennas up and have realized all that this while that they were thinking that pediatric OSA is just tonsil and adenoid. I'm sure after his lecture, your eyes have opened up to how much more there is in pediatric OSA. He's elaborated a lot of points, so I think we will keep that for the end, Vijay, and we'll see if there are any questions now, because Dinesh hasn't sent me anything, so I'll take all the questions at the end.
At the last, yes.
Yeah, so I have, but very beautifully explained about so many things about pediatric OSA, just not tonsil and adenoids.
Thank you.
Our next speaker is Dr. Srinivas Kishore. Dr. Srinivas Kishore is from Hyderabad. He has been our immediate past president of ISSA also. The best part about this gentleman, whom I've also known all these years that we have been in ISSA, is his very methodical, evidence-based and literature-based evaluations of everything that he does. not to mention that surgically fantastic, and he's probably one of us who's known for his multi-level surgeries all in one sitting. Keeping that apart, today I'm going to now ask him to speak about where Vijay left off, because Vijay's last few slides would have really opened your eyes to the fact that tonsil adenoids does not end everything. And he's very beautifully elucidated the fact that, you know, tonsil and adenoids also needs to be thought about, and there is a lot of residual OSA that happens in those patients after tonsil adenoids and in those patients with syndromes. So I'm going to request now and hand it over to Dr. Srinivas Kishore to please take over and talk to us about management of children in OSA post tonsil adenoids. Over to you, Srinivas. You have to unmute yourself, Srinivas.
Hello, everyone. Can you hear me?
Yes, now you're absolutely audible. Over to you.
Thank you very much, Seema, for your kind words. Thank you, Sun Pharma again. Thank you, IASSA. And thank you all those delegates who have actually tuned in and chose to spend your very precious Sunday evening with us. So without further ado, let me just go ahead and start with my talk. As Seema very beautifully put it, I'm going to start where Vijay ended. I'm going to talk about adenotonsillectomy. I'm going to talk about the residual OSA post adenotonsillectomy. One second. One second, guys. I seem to be having some kind of a...
No, so if you had put this up before you shared the screen, again do the same thing that
Yes,
you did.
I will probably just do it again and...
Start again.
Yeah, can you see the screen now?
Perfect, perfect. Go ahead.
All right. I have a small disclaimer. There are lots of pictures and videos, and all the pictures and videos have been consented for. As you saw, and how Vijay beautifully put it, adenotonsillectomy for obstructive sleep apnea in children is considered the gold standard. Not only as what Vijay said, it's considered gold standard by the American Academy of Sleep Medicine, the American Academy of Pediatricians, and our own American Academy of Otolaryngology and Head and Neck Surgery. The success rates, however, are all over the chart. Success rates can range anywhere between 27 to 80%. And to me, whenever I look at such a broad success rate, anywhere from 27 to 80%, that means there is something not right there. In fact, the cure rate, that means the AHI going below 1, is also about 40% for adenotonsillectomy. But our discussion is not here, our discussion is here. So the success rate, if it is between 27 and 80%, we need to know who are all these patients who are in between 27 to 80. I would like you to just look at this video and just pay attention to this child. This is a child in whom adenotonsillectomy was done 6 months earlier for pediatric OSA. Now, obviously, any one of you, when you see the video, would obviously come to the conclusion that yes, this child is not well. Now, this is a watchpad study of another child whose pre-op RDI was about 34.6 and post-op RDI is 5.6. And according to the pediatric metrics of measure, yes, I have done an amazing job, brought down the disease burden from 34 to 5.6. Yes, excellent. But have I succeeded? No. As you know, according to the pediatric metrics of measure, this child still has residual sleep apnea. moderate residual sleep apnea. Here is another patient, a teenager, pre-op 45, post-op 4.9. Now, all these are examples to basically tell us that we're almost there, but we're still not reaching the finish line, which we are supposed to. So, dear colleagues, there are significant number of patients with persistent sleep apnea if you really look at them. And most of them, unlike adults, see, when you take care of an adult patient, if one modality of treatment does not work for them, you can just put everything to the side, put them back on a CPAP, and then make them stabilize the condition, and then go back to doing what you can to try to help these patients. But unfortunately, you do not have that CPAP cushion in children because they are either unable to put it on for some reason or suboptimally treated by it. For example, if you have a craniofacial child with different morphologies, there are no custom-made, nowadays we have custom-made masks for them, but till date we don't have very good masks made for them. And even if you get a custom-made mask for that particular individual or the child, they're suboptimally treated by it because they don't put it on for the desired period of time. So if you really sum it into numbers, 15 to 33.7% of patients have persistent symptoms in spite of adenotonsillectomy. And these are symptoms brought to us back by the very parents who brought the child to us in the first place. Now, because it's very difficult to do level 1 sleep studies, you sort of try to get objective analysis of what is, subjective analysis of, subjective analysis of what is going on with this patient. And a very good tool in doing that is what we call as the pediatric version of the OSA 18 scale, wherein there are a lot of questions that the parent is actually asked and they answer. And then any score above 60 should raise a red flag. Now, there are other questionnaires that also can be used. This is called the I Am Sleepy questionnaire, which is very popular in Australia. And there is a parent version and a child version to this. This is pretty easy. And these questionnaires sort of tells us the disease burden explained in the form of the subjective severity of the disease. Now, we are all about shortcuts, right? So there are biomarkers that are out there, and it has been shown that highly sensitive CRP may aid in determining and isolating those patients who have not been treated post adenotonsillectomy. So if there is one test that if your patient is asking you, and our patients are all about tests, and if they ask you, doctor, is there some test that I can do that that would tell us if my child is having residual sleep apnea? Yes, you can get a highly sensitive CRP done, and it's a pretty decent study that is being done with an N of about 182. So it's a pretty robust study. Now, there are kids like these, kids with Prader-Willi, kids with Lawrence-Moonbedel, kids with all kinds of syndromes who after adenotonsillectomy have significant residual symptoms and hence the disease. There are also kids like this. I would like you to pay attention to this video. Now, I don't have to be a sleep apnea specialist. Any decent ENT surgeon would know that this is not stutter, this is not snoring, this is stridor, for whom an adenotonsillectomy was done. So what are the effects of untreated obstructive sleep apnea in terms of the metabolism? As you know, and it is in adults, there are cardiovascular effects, there is hypertension, there is right-sided heart failure, that means type 2 respiratory failure, pulmonary hypertension, which is very high, ventricular remodeling, two biggest issues in terms of neurology and behavior, neurocognitive symptoms and behavioral issues. And we all know ADHD is very closely related with sleep apnea. Enuresis, wherein we know that ADH is released in kids with recurrent apneas, and somatic growth retardation. Now, if at one side, all these metabolic things are going on the opposite side, because of reduced nasal breathing, look at these kids. Just look at their upper airway. Now, there is a constricted maxilla. There is a deviated nasal septum that is forming because the upper airway is crashed, the upper part of the maxilla or the roof of the maxilla is crashing into the skull base. And that's one reason why septal deviations happen. All these basically result in mouth breathing, which lowers the tongue and causes extended head posture. Now, lowering the tongue would cause a constricted maxilla. That means what? There is a developmental hypoplasia of mid-third of the face, including the piriform aperture. So no matter what, even if you cause an empty nose syndrome for these patients, clearing off all the turbinates, these children will continue to have increased airway resistance. And extended neck postures will cause lowered mandibular posture. Now, this pathophysiology, dear colleagues, will shift into an awake disordered breathing. That means what has started off as a sleep-related breathing disorder is now become an awake breathing disorder. And then the Pandora's box opens. Then there's upper airway resistance syndrome, there is temporomandibular joints, and so on and so forth. It is also known and published that there is a decrease in the volume of the brain. If you look at controls and OSA children, the volume of the brain actually decreases. Thereby, there is a significant cortical atrophy in OSA children when compared to controls. That means kids who are like sponges, they were absorbing everything, language, knowledge, they are not able to do so because of reduced cortical activity. So, can we predict these potential failures? Can we before doing an adenotonsillectomy, can we predict who are the ones that we are going to fail? These four sort of conditions would sort of give you an idea as to which of these your patients you are going to fail. Syndromic, craniofacial anomalies, obesity, and a comorbidity of allergy. Be careful with these patients. So, the high risk criteria according to the ASM are obesity. And if you look at this slide, and this is a recent meta-analysis that showed that if you were to do an adenotonsillectomy in an obese kid, your success rate is an abysmal 10 to 25% compared to a normal child who would achieve a 70 to 80%. Down syndrome, your success rate is 30 to 60%. Craniofacial anomalies, neuromuscular disorders, especially cerebral palsy, sickle cell disease. Do you know why sickle cell disease kids develop are high risks? Because most of these kids require splenectomies. And once the splenectomy is done, there is a rebound growth of lymphatic tissue. And there is a huge adenoids, huge tonsils. And even if you remove the adenoids and tonsils, they tend to grow back. Mucopolysaccharidosis, lingual tonsil hypertrophy, and one big red flag is the older the child and the higher the preoperative AHI, the lower is your success rate. These high risk factors, you should have it at your subcortical level, because the moment a child comes to you with adenotonsil hypertrophy and you know that is obstructive sleep apnea, if they are fitting into any of these boxes, mind you and please mind the parents and counsel them. Now, very severe obstructive sleep apnea kids, that means we're talking about 30, 40 AHI. It has been shown that both nocturnal hypercapnia and hypoxia on the preoperative PSGs are also predictors for persistent obstructive sleep apnea. So if you have a child who's retaining carbon dioxide, please remember that this is also a red flag for you when you do adenotonsillectomy. So persistent sleep apnea, obviously in a post-adenotonsillectomy child, is a challenge. It's a challenge not only to the parents who have brought the child, and in our Indian scenario, you know, the grandparents obviously come in, and we are talking about the paternal grandparents, the maternal grandparents, and this is a whole emotional ball game going on. And you as a poor ENT surgeon is stuck amidst all that emotions. You might have not done the procedure, but you're now stuck in that. So we should also remember that persistent OSA is now a multi-level disease. It's just not at a single level anymore. And it's very difficult in the pediatric age group to get a comprehensive upper airway examination. It's very difficult to do MRIs. It's very difficult to do even a flexible laryngopharyngoscopy. So before we go in and do all those things, is there a role for conservative management before we jump and do any kind of heroic surgeries that we would like to do? Yes. Weight loss, dear colleagues. And we know in this generation, weight loss in teenagers and in the teenagers has become a major problem. And by just losing weight by 32%, OSA was successfully treated in 80% of kids in whom obesity has caused the OSA. You should remember that. If you have a child who's obese and you found out by a sleep study that these children is having OSA, just by losing weight, you've treated the child in 80% of the patients. So you're obviously going to go out of the equation. So look at the second thing. So we obviously know that, look at the success rate when you do adenotonsillectomy in an obese child vis-a-vis doing just an doing just a weight loss in these obese children. So weight loss is a significant factor that we need to bring in this situation in kids who have obesity-driven OSA. Now we all know, and Vijay also said, that montelukast and intranasal corticosteroids have a huge role. Now why? Why do they have it? Because it has been shown that in children who are obstructive sleep apnea, there are more leukotriene receptors in the adenoids and tonsils, and that is why your montelukast works in children. But it can't be just a half-hearted treatment. When you give montelukast and intranasal corticosteroids, you give a wholehearted treatment. The duration of therapy has to be for 3 to 4 months. You cannot give up at the end of 1 to 2 months. But remember that this has to be done for residual mild OSA and not for severe obstructive sleep apnea or moderate obstructive sleep apnea. What about CPAP? The mean usage time for a CPAP in a child is 2 hours. That is obviously not significant. However, it is useful in children who are having neuromuscular problems, especially in whom there is hypoventilation because of all kinds of syndromes that these kids may have, and kids who also require high positive end expiratory pressures to keep their airway open, because the apnea happens at the end of expiration. What about myofunctional re-education? I would like to play this video. Are you getting the audio?
No, there's no audio to it yet, Vijay.
There is no? Okay.
No.
So I'll just...
Again, if you really need the audio and it's that important, stop sharing screen, do that again, switch on that.
I think we'll probably, I'll just let the video run. Just you can even see the... Are you able to see the video?
Yes, very clearly.
So myofunctional therapy is very, very important even for our regular adenotonsil patients, to re-educate them to breathe through their nose instead of breathing through their mouth, because these kids have become habitual mouth breathers, and breathing through the nose is very pivotal and primary. Now, let's take the narrative a little forward. Now you've tried all conservative methods, and you know that conservative methods are only valuable for mild residual obstructive sleep apnea. Now, what about all the moderate and severe? So you need to evaluate them. There are three ways that you should be using to evaluate. One is polysomnography. Now it becomes very important that you use some kind of a polysomnographic technique to evaluate residual obstructive sleep apnea. Another way to evaluate them is to actually do a flexible laryngopharyngoscopy. And most of us now know, when we are evaluating our adenoids, to put the flexible scope into the nose to evaluate your adenoids. It's challenging a little bit, but not impossible. Drug-induced sleep endoscopy, which earlier has been started in the 2000s to evaluate kids with residual obstructive sleep apnea, has now gained a lot of importance, and also cine-MRI. So these are the three methods by which you can evaluate and take this game forward in order to resolve their problems. Also, there is a lot of evidence out there that shows that both DICE and cine-MRI have used, when used to direct surgery, that means DICE-induced, DICE-guided or cine-MR guided surgery gives better improvement than just going and doing something very blind. Thanks to Dr. Vijay, this is a cine-MR that I obtained from him, because I don't do too much of cine-MR. So he's been kind enough to send this image to me. Thank you, Vijay. This is a picture of a cine-MR. I'm not able to run the video for some reason, but yeah, you'll have to just make do with this. Sorry about that. So I'm going to talk to you very quickly about DICE in persistent OSA in kids. Now here is a DICE. This is not post TNA. This is a child who slightly on the obese side. You can see the adenoids. Pay attention to his mouth. So even in this child, we know for sure that even after we remove those adenoids and tonsils, because of the way his mouth is, because of the way his upper jaw is, he's obviously not going to get cured. So the method is, it's done in the outpatient. The child, unlike in adults, is given an inhalant anesthesia, generally sevoflurane, and you can either give dexmedetomidine and you can give concurrent ketamine as a boluses to maintain the sedation. Now, the scoring, there is no universal scoring system as yet in the pediatric age group, but yes, you can actually start off and give things to the adenoid, the velum, the lateral pharyngeal wall, the tongue base, and the supraglottis. Now, what is very different from adults is that adenoids and supraglottis has been brought in, because laryngeal OSA and nasopharyngeal residual disease is significant, and we need to take that into consideration. Since we spoke about laryngeal OSA, a few words. There is an entity called stage-dependent laryngomalacia, dear colleagues, basically coined by Amin and Isaacson in 1997. So what does this basically mean? So these are older kids. These are not the young kids, the newborn kids that we treat for laryngomalacia in the neonatal wards. These are kids above 1 year of age. These kids are normal, hale and healthy when they are awake, but the moment they go into sleep, they start developing stridor. Now, this is a picture of a child with on a drug-induced sleep endoscopy before sedation and after sedation. Supraglottoplasty is the treatment of choice for these kids. There is excellent evidence out there to show that in these kids with stage-dependent laryngomalacia, supraglottoplasty gives good results, and the results remain. Now, when you come to surgical management of residual OSA, at the level of the palate, you need to be conservative. So I use a lot of expansion because I use expansion in adults as well. So the principle is the same, but you want to be a little more conservative when it comes to using hot techniques. So I use a lot of cold steel because I'm using cublator to just cauterize the tissue, but I use cold steel because I've had very bad experiences with nasopharyngeal stenosis. So when I do these kind of procedures in kids, especially, I do a lot of cold steel dissection. In my hands, cold steel has worked beautifully. Expansion sphincter pharyngoplasty is one procedure at the level of the palate. If you see that on your dice, will help you to get good results. Lingual tonsil hypertrophy is something that you see very commonly, especially in kids with allergies. So this is almost a grade 4 lingual tonsil hypertrophy. 6 months after adenotonsillectomy of a child, the idea is to remove every bit of the lingual lymphoid tissue that is out there and to actually bare the base of the tongue and expose the valvula. So what starts off here should basically end this way. Now, what about persistent nasal obstruction? These are some of the patients that we see post, even before you do adenotonsillectomy. So when you are confronted with such patients, yes, you need to clear off the adenoids and tonsils, but your treatment just doesn't end there because these kids have significant retropalatal obstruction because their maxillas are very narrow. And if you look at the prevalence of malocclusions in children, it's a staggering 89.9%. That is a very high rate compared to a control group. So 89% of pediatric malocclusions are associated with kids with OSA. So that means every single child of yours after an adenotonsillectomy or before an adenotonsillectomy does require a dental opinion. Please take it from me. So these are some of the kids with persistent nasal obstruction. Look at the way their alveolar arch is. So rapid maxillary expansion, these are images that my pediatric dental colleague, Dr. Gayatri, has kindly shared with me. So what it basically does is it expands this. Now, what's the big deal in expanding this? The reason why you have to expand that is because the tongue has to thrust itself against the hard palate. There has to be a coupling that is formed. So it's just not about the genioglossus stone. It is also about the negative pressure, little bit of negative pressure that is created between your tongue and the hard palate, and that negative pressure is also actually holding the tongue from going backwards. So if the upper airway skeletally is like this, and you would paste them with a very expensive hypoglossal nerve implant, it's still not going to work if the maxilla is still going to be like this, because even if you improve the genioglossus stone, the coupling between the tongue and the hard palate is very important. And that is why we need to increase the dimensions of the hard palate. This is an example of a patient of ours who was pre-expansion and post-expansion. And you can see the roof of the mouth is the floor of the nose. And once that increases, it's much better. So management in a nutshell: CPAP, oral appliance, intranasal corticosteroids, add in a turbinoplasty if you have allergy history, conservative palatal surgery based on resection or channeling based on what your tongue-based phenotype is. And what is pivotal to all this is weight loss. So in conclusion, adenotonsillectomy is still successful. It's not that you're going to throw it out of the window. It is very important. But yet, remember that there are a significant subset of pediatric patients who will continue to have obstructive sleep apnea even after adenotonsillectomy. It is important for you as an ENT surgeon to pick up these high-risk kids, talk to the parents, and tell them the entire treatment paradigm instead of just telling them that, oops, the procedure didn't work, now we'll do this. DICE or dynamic MRI can help to identify the anatomical causes for residual obstruction, and they can guide and customize the adequate surgical requirement for your patient who has residual obstructive sleep apnea post-tonsil adenoid. And I would like to end this talk with the saying by Ralph Waldo Emerson, to know even one life has breathed easier because you as an ENT surgeon has lived. This is to have succeeded. Thank you, dear colleagues. Sima?
Yeah. Wonderful, Srinivas. Thank you so much for that beautiful illustrative talk. You've actually just reiterated everything and confirmed to us that it is not so simple as just a tonsil adenoid. So wonderful points that you've touched on. I made a note, and I think we will, like decided, take questions right at the end for all three of y'all.
Sure.
But thank you very much for elucidating everything that was needed to talk into the residual OSA.
Sure. Thank you, Sima.
Our, excuse me. Our next speaker is Dr. Roshan Rayan.
I spent some time reading a book on muscle.
Sorry?
Yeah.
Right. So our next speaker is Dr. Roshan Rayan. He's a senior consultant and a pediatric dentist in Chennai. He's a US board certified orthodontist, and he's got more than almost 11 years of teaching experience, as well as almost 15 to 16 years of clinical experience, especially in dealing with pediatric related issues with mouth breathing and rehabilitation of all of them. So as again, where Srinivas has ended, where he spoke a lot about the expansions and things that are needed to get the pallets in place, I would now request Dr. Roshan Rayan to please come on to the screen and guide us with regards to the dental perspective, or let's say the pediatric dental perspective for pediatric OSA. Over to you, Dr. Rayan.
Good evening, sir. Am I audible?
Absolutely.
Audible, yeah.
And your screen is also well in place.
Good evening, one and all. Very big thanks to the Indian Association of Surgeons for Sleep Apnea for giving me a wonderful forum to tell you about what, from our perspective of what we think about pediatric OSA and how we handle it. And a big thanks to Dr. Vijay and Dr. Mohan Kameswaran sir, with whom I have been associated for more than 5 years, and we have been working on a lot of pediatric OSA kids. And coming to the topic, pediatric OSA from pediatric dentist perspective, what we see and where we see and when to intervene and what to be intervened and what are the modalities, everything is going to be discussed today. The target audience for today is going to be mainly ENT postgrads and eminent clinical practitioners and academicians are there with us who are into this topic. So what is our outline for the presentation? A note on the prevalence, the dental findings in the pediatric OSA child, a note on residual OSA, what we generally do and how we look into it from our aspect. Evidence-based assessment, few articles I'll just scroll through, and a lot of articles are there, but due to time constraints, maybe we can take it as a printout later. Clinical cases, about 3 to 4 cases I will discuss. And Vijay has specifically asked to please touch on adult OSA also, what are the treatment options are there. But I generally don't do it. It's under the purview of an oral and maxillofacial surgeon. So Dr. Pradeep has given me some inputs about that. I'll be sharing with you in this presentation. And usually to keep the presentation engaging, I usually have a game for the audience. So pertaining to my presentation, I'll ask at the end of this presentation 3 questions. Maybe you can use the chat box, or maybe you can tell the audiovisual guy the answers for this. So, and a take-home message for the day. Okay. So the note on the prevalence. In the past 5 to 8 years, what we have generally seen is the number of cases in a period. Suppose we are seeing about 10 cases. That is about 2 to 3 children in about 10. That's about 20%. We are looking at findings with dental findings pertaining to OSA. That's because of the change in lifestyle, the obesity pattern, and because of which we see all these kind of dental findings. So it's a very, very huge numbers. The numbers are becoming very huge in nature. And pediatric dentistry as such, this clinical condition, we are looking at it very seriously, because the role we are going to play is very important in these kind of children. So coming to the common dental findings, the common dental findings are tongue thrusting, which is a different modality pattern of swallowing, which they develop, a narrow maxilla, a posterior crossbite, protruded upper front teeth, is an excess overjet, a short mandible, and a convex facial profile. These are the characteristic common dental findings which we see, and these findings we call it as a class 2 profile children. This finding can also be seen in a non-OSA child which has a clear genetic pattern. Okay, so we need to really rule out whether it's a OSA which is causing this issue, or it's a genetic pattern along with which secondary OSA is coming. Okay, so I given a small mnemonic for that. It's called the TNPSC. TNPSC means Tamil Nadu people will know. It's called Tamil Nadu Public Service Commission. So we have added a small P to that, TNPPSC. So these are common dental findings we see in a characteristic pediatric OSA child. At the same time, the reverse pattern is also seen. There is an underdeveloped maxilla, a reverse overjet, and a concave profile. Okay, so this, but the number of cases we see of this category is very less. So I have just kept it aside. Suppose we are seeing 10 cases, about 8 is about class 2 profile, and about 2 cases are about class 3 profile. So when you know the normal, you can exactly identify what is abnormal. So for us, it's very basic, but for you in ENT people, it could be little enlightening to see what is normal and how we can differentiate from abnormal. So I'm just going to go through a few terminologies on that. Normal overjet is a normal horizontal overlap of upper teeth to lower teeth. That is what you see here. But excess overjet, you can see, is the horizontal overlap is more than 8 to 10 months. That is why the teeth are very much in forward and the lower teeth are very much in backward, resulting in a short mandible. This is a typical class 2 profile, what we call it as. And this is what you see in a classical OSA child. This is a normal overbite. This is a vertical overlap where you see 80% of the teeth, lower teeth are visible, whereas the deep bite, you don't see any visibility of the teeth. Again, this is a characteristic of a class 2 profile. A deep bite is always seen in children with a class 2 profile OSA kid. This is what is called as anterior overbite. Normally, we have the upper teeth overlapping the lower teeth. In this situation, the lower teeth is overlapping the upper teeth. Okay, this indicates either the maxilla is narrow, or the mandible is coming forward, or the maxilla is little underdeveloped. And this is what is called as a posterior crossbite. Posterior crossbite also indicates a narrow maxilla. This is a characteristic posterior crossbite what we see, but this is very rarely seen in a clinical scenario. A normal clinical scenario, what you see is a hidden posterior crossbite where the overlap is almost edge to edge in nature. But these kind of children are also potent candidates for OSA. You may think that there is not characteristic posterior crossbite is not there, but these are hidden crossbites. This is what we see very commonly in a clinical scenario. And this is a pediatric child who is having a typical edge-to-edge bite. And when you see a typical edge-to-edge bite like this, it clearly indicates that the maxilla is narrow. But on a clinical scenario, we will not be able to identify. But we take a study model that we take a measurement and then we assess the maxillary measurement. Then we come to know that the maxilla is really narrow compared to the mandible. And these are the few profiles we gauge the people, patients. This is a straight profile. This is the characteristic good profile. This is a convex profile. This is a characteristic of a OSH kid. And this is I already told you, the reverse overjet and the excess underdeveloped maxilla. So this is also seen in a few cases of OSA children, but the prevalence is comparatively less. The convex profile is the main culprit in a pediatric OSA child. So these are lateral cephalograms to show you the same profile, same patients, but lateral cephalograms help us to assess the airway also, and after the treatment also, the facial profile and the skeletal structure, everything we assess using this lateral cephalogram. So what are the common investigative tools we use to completely come to a conclusion whether there is a prevalence of a class 2 profile and there is some issue in the airway. A good extraoral and intraoral photographs, lateral cephalogram, and study models. Study models are something like this. We take and we do a model analysis and then take some measurements, transverse measurements we take, and anteroposterior measurements we do, and then we come to the conclusion whether the maxilla is really narrow or not. So how do we approach? What is the age at which we can approach these kind of children? So basically, all these abnormalities, what we call it as a significant, one term what we use is called as malocclusion. But malocclusion per se can happen due to various reasons. It could be genetic, it could be functional, it could be habitual, and so many factors are there. So generally what we classify is it a problem of OSA purely functional in nature? Because of the functional problem, the teeth are all in bad shape. It's becoming a narrow maxilla, or a posterior prospect is developing, or a tongue thrusting is developing. In that case, if it's a purely functional in nature, then we go ahead treating it as early as possible. Then the treatment is more stable because there is age by the side. Okay. And if it is a combination of genetic and functional, in that situation, we would like to postpone the treatment a little later, not to intervene at the age of 6. Maybe around 9 or 10, we start intervening, and maybe a secondary correction at the age of 11, 12, followed by retention phase by about 14 or 15. So we are looking at a 10-year plan with the early follow-up from 6. But a purely functional problem, we can start treating by the age of 6 years. So that is how the intervention goes. Coming to the residual OSA, a note on the residual OSA. So most of the time what happens is you do the adenoid tonsillectomy, and after the surgery is done, the child typically starts breathing, mouth breathing is still there. So what generally happens is, if the child has been an OSA child for about 3 to 4 years, the pathology of the tissue has made the child breathe through the mouth, and over a period of time what has happened is the brain is programmed to know that breathing through the mouth is the norm for the child. So even after the surgery is done, the child keeps breathing through the mouth. In that situation, we need to intervene. A dentist, a pediatric dentist, anybody, the dental fraternity has to intervene, and a referral has to be done to rule out the habitual component of
Dr. Roshan, sorry to just interrupt you. There are a few people who have been saying that your presentation needs to go a bit slow. Since it's a different field, they are not able to comprehend. You're going a little too fast. So
okay.
Just go a bit
slow. So the time was 20 minutes. That's why I was going a little fast on that.
Yeah. Go ahead within the.
Okay, I'll go slow, sir. No problem. Okay.
But, yeah, just so that they can comprehend, and then we'll manage time at the end.
Okay, sir. Okay. Because I have a lot of content, that's why I wanted to keep it a little. I was going a little fast.
Go ahead.
Okay.
Go ahead.
Residual OSA is the thing where you have the tissue surgery done, but you are not able to. The child is still breathing through the mouth. So what exactly has happened at this point of time is. The pathology is clear, but still the brain is programmed to breathe through the mouth. So the child continues to breathe through the mouth, and because of this, again, the reactive lymphoid tissue starts growing. So in these kind of situations, the habitual component has to be treated. So in this situation, we give some kind of appliances to rule out the habitual component. The appliances, this is a typical mouth breather child. Appliances, what we use are oral screen. Okay, in the oral screen, what you can see is small holes are there. So a child who has been breathing for 4 or 5 years on a mouth breathing pattern, immediately you want to change and you want to give an appliance, the child will not be able to accept that. In these kind of situations, we try to retrain it on a slow pattern, and some myofunctional exercises like lip seal closure and all those things, and they need to wear this appliance in the night. And the duration of the wear is going to be about 3 to 6 months. Then only the brain gets reprogrammed to go ahead with the stopping the habit. Okay, so this is a custom-made appliance fabricated with the heat cure acrylic. This is what is called, it's a ready-made appliance called the Myo Brace, which Dr. Vijaya had also talked to you, Dr. Srinivas also talked to you about this. And this is a ready-made thermoplasticized silicone rubber material. This also helps to correct the teeth alignment a little bit, and also helps to keep the muscle force away, so that and also helps retrain the tongue and the breathing pattern. So these kind of appliances will be helpful post-surgically with a dentist who can handle these kind of things. And recently, what I have generally felt is some patients who are not compliant wearing a removable appliance, because removable appliances with kids, the key for the removable appliance for kids is motivation. We need to really motivate the child, we really need to motivate the parent, and we need to give them rewards. Then only these things work. So otherwise they don't wear it in the night, and sometimes they put it and they just throw it off. They go to the restroom and it falls inside the restroom, and so many accidents like this happen. So we want to if the compliance you feel it's poor, this chin strap works well because it doesn't put major any kind of orthopedic or orthodontic or teeth force. Just they need to wear it, and it keeps the mandible closed with the mandible maxilla, and a good lip seal is there. Post surgery, you can give them this default, and this could also help you in the long run for a residual OSA child. So a narrow maxilla with posterior crossbite clearly 80% of the time or 90% of the time indicates there is an upper airway obstruction. There is OSA. And if there is a posterior crossbite, we go back to the history and we ask them if there is bedwetting. 50% of the time they say there is a positive history of bedwetting, nocturnal enuresis. So a narrow maxilla indicates there is enlarged tonsils and adenoids. There can be habits like thumb sucking and mouth breathing and snoring at night. And this point I would like to enlighten for you. A prolonged bottle-fed child or a mother-fed child or nocturnal mother feeding at will at the early stage like 2 years or 3 years greatly alters the total facial profile, the total dental architecture, and it lands up in the typical class 2 profile, what we call it's a short mandible, protruded upper front teeth, and these children are potent candidates to land up with OSA at a later point if they are becoming obese. So this is a very important history you need to take when you do taking the history for OSA. And of course, speech difficulty, pronunciation issues. Look for evidence of cheek biting and other things you all have talked about. I'm not going into details about that. Some evidence-based articles are there. I'm just scrolling through, but I'm not going to discuss that in much detail. Maybe we'll take a picture of it, or I'll give you a PDF of it. Maybe you can share it among your groups due to time constraints. And the impact of rapid palatal expansion on children, it was clearly proven that it increases the general health of the child. Orthodontic expansion also helps to reduce the nocturnal enuresis because the oxygen saturation increases, and because the oxygen saturation increases when you do the expansion, automatically the antidiuretic hormone secretion is much better, and because of that bedwetting is stopped or the frequency of bedwetting is reduced. So these are some articles. So the evidence-based summary clearly states that there is sufficient evidence to state that dental malocclusion, upper airway obstruction, and nocturnal enuresis are coexisting factors leading to OSA. So how do we go ahead treating this problem from a dental perspective? The first and foremost is a comprehensive ENT evaluation with a good OSA pertaining assessment has to be done with all the necessary investigations and rule out all the upper airway obstructions. If anything is there, we need to plan for surgery. And what the treatment, orthodontic treatment, whatever we are doing is called intercept to orthodontic treatment. Intercept to orthodontic treatment is nothing but we are not looking at cosmetic correction at all. We are looking at only functional correction. There is something called as corrective orthodontic treatment which happens at a later age. In that only we do teeth alignment corrections. In intercept to orthodontic treatment, we only do corrections of jaw positioning. So this is the stage 1 correction what we are looking at the age of from 6 years to 12 years. Second is to do a urological opinion, take a urological pathology if anything is there. Otherwise, if it is because of the narrow maxilla which is causing the oxygen saturation decreasing, then we can go ahead. So a urologist opinion is also to be taken. And then we start with the maxillary expansion. So the maxillary expansion appliance duration of treatment is about 3 to 6 months. So how much of expansion is required? All those things I'll be discussing with you now. So these are sometimes slow expanders. This is called coffin spring. This is a plate with a screw. These are removable in nature. This is called Quadrelix. This is a fixed appliance, but again, it's a slow expander. So what you see here is called the Hyrax. What Dr. Srinivas sir and Dr. Vijay had discussed with you. This is called Hyrax. The full form of Hyrax is Hygienic Rapid Expansion Appliance. This is the most commonest appliance we use for expanding the maxilla and correcting the crossbite and improving the oxygen flow and decreasing the nasal airway resistance, everything. This is the most common and the appliance of choice. This is another fixed appliance called the Has Expander. Some cases I'll be showing to you also now. And this is a narrow maxilla. After expansion, you can see the difference in the transverse dimensional increase. This is a maxilla. We will see the narrow maxilla after the expansion. And this appliance here, what you see here, this is called transpalatal arch. So the duration of the appliance is going to be for about 3 to 6 months. After the appliance is removed, we give this transpalatal arch. What exactly happens? The mid-palatal suture is opened, the teeth are getting aligned, the dimension is going to increase, but there is a residual relapse which can happen. So whenever we plan for expansion, suppose we are planning for 4 mm of expansion, we always do 6 mm of expansion. We always take a little more, a 2 mm buffer, so that even if there is some relapse happening, we are coming to that stage, okay, what we want, okay. Once the expansion has happened, to prevent relapse, till the bone formation completely happens, we give this transpalatal arch. The transpalatal arch helps to prevent relapse, and this is kept in place in the mouth for about 2 to 3 years. So this has to be there in place for about 2 to 3 years, okay. So how do we do this expansion? There is a small, I'll be showing you a video on that. There is a small key kind of thing, and there is a small hole. This has to be done especially by the parent. The parent has to be really motivated, and we teach them how to do it, okay. And they have to train themselves to do it, and we show them in the outside form, the appliance, and we ask them to do, then we place it inside the child's mouth, and then we ask them to do that. So I'll be showing a video on that so that you can get to understand it much more clearly, okay. So that is how the expansion happens. So every day we are supposed to do 1 quarter turn. So 1 quarter turn gives an expansion of about 0.25 mm. Suppose we are looking at 4 mm of expansion. So we are looking at how many turns? 16 turns has to be done on a daily basis. And how the patient has to put we give a chart to them. So they have to tick on the day which they are doing the expansion. And whenever they do this expansion, they have to do it in one particular time in a day, say evening 8 o'clock, 8 p.m. or evening 9 p.m. Before going to bed, they are going to do it. Every day they are going to do it at that time only. So we are given strict instructions to them, and they follow that protocol. And after the expansion is done, they come for a review, and we see how much the expansion has happened. Suppose sometimes if the expansion we need a little more, then we ask them to do another 5 or 6 turns, and that's a complete clinical perspective of assessment, and then we tell them to do the turns. Okay, so that is how this expansion happens. And after the expansion has happened, there is a hole here. This hole is close to the cement, so that there is no more expansion or constriction going to happen. And what is going to be, this appliance is going to be still there in place for the next 3 to 4 months. So what exactly happens when you do the expansion? When you do the expansion, suppose we are doing 4 mm of expansion, the volumetric gain in the roof, we are working on the floor. The nasal cavity is considered like a cylinder. So the volumetric gain, what we are going to gain is, the cylinder is nothing but length into breadth into height. So in this situation, 4 expansion, if I am doing 4 into 4, 16, 16 into 4, 64% increase in oxygen saturation we can expect from the existing volume what the child is breathing. So that's going to be a very good improvement, a very good change in the oxygen saturation for the child. So the hypopneic episodes, what you're talking about in the OSA, is going to reduce to a great extent after the expansion is going to happen. They come and tell us there's a good change in the child's breathing pattern, there's a good change in the snoring sound, everything. The parents really appreciate that. But this is purely a functional correction, and there is no cosmetic correction involved in this per se. So a couple of cases I'm going to show you. This is a typical short mandible child, a moderately obese child. After expansion and bringing the jaw forward, we achieve this straight profile. So bringing the jaw forward, the appliance of choice is called as a fixed twin block. So here it's a combination of a fixed twin block with Hyrax, what we are given for the child. The upper arch has a Hyrax with the twin block. The twin block ensures that the lower jaw mandible is coming forward. It doesn't go back. And what exactly happens when you bring the mandible forward? The growth center of the mandible, the main growth center is the condyle. So the condyle starts getting remodeling and bone formation happens when the appliance is there for about 3 to 6 months. So there is a segmental complete increase in the length of the mandible which will happen because of the significant remodeling of the condyle which is happening. So once we remove the appliance, the mandible doesn't go back. So that is the exact mechanism which is happening. This is excess overjet with a deep bite, and after the appliance is removed, this is what we achieve. Sir, am I in a lot of speed or is it okay, sir?
I think you can finish now as you are going, because I think they were wanting to not understand the earlier part. Now they're picking up, so you can go at your little faster speed.
So this is what we achieve after this. Yeah. This is what we achieve after this with the appliance. This is also a typical class 2 profile, what we call a short mandible, protruded upper front teeth. You can see the child stooping the head a little forward because the reason to get a more airway, to get a little bit better airway, the child is actually keeping the head a little forward. So in this kind of situation also we use this appliance. This is the 45-degree angulation what we give to keep the mandible forward. This is again the fixed twin block with Hyrax. And after the expansion, and you can see the profile, short mandible, the straight profile, the craniocervical angulation getting better now. This is another child where the maxilla is underdeveloped, but the mandible is normal. And because of that, the tongue position is not proper. Because of that, they land up with heavy snoring and nocturnal enuresis. So this is how the profile is. This is called as a class 3. This is a concave profile, what we see. And this is a reverse overjet, where the upper teeth are back and the lower teeth are forward. We call it as anterior crossbite. And of course, here also, it's a hidden posterior crossbite is there. In these kind of situations, we take the X-ray, you can see the typical positioning, altered positioning of the teeth. And again, I tell you, 10 cases we see, only 2 cases are like this. 8 of the cases are a typical class 2 profile, what we call the convex facial profile. And this is the appliance what we use. And here I have used a quad helix. This is a slow expander again. Hold the mandible and try to bring the maxilla out with a kind of a small elastic in place. And this is called as a face bow. So this appliance totally is called as a tandem appliance. And this is helpful to bring the maxilla forward. And we get a straight profile. So from this, we'll be able to achieve this. These are some common anti-storing devices, the maxillomandibular repositioning device. And if you need more force, a reverse spoon headgear will be the appliance of choice to bring the maxilla forward. And if you want to hold the mandible in place, chin cap. This is an appliance called this chin cap we give to hold the mandible in position. So I'll prevent the mandible from going forward. And this also helps to prevent snoring. So coming to adolescence or adult, what are the options we have? Suppose the growth has completed, this maxillary expansion we can do till about 13 to 14 years. Suppose 15, 16-year adolescents, young adult, will not be able to do much expansion happening. Only the tipping of the teeth will happen, but the jaw will not expand because the sutures are all completely closed. In this situation, a surgical option is there, the SARP. The SARP is nothing but surgically assisted rapid palatal expansion. So the appliance, the maxillary expansion appliance is in place, but we do a small surgery to cut the sutures, to disengage the maxilla from the nasal cavity, and so that the expansion happens faster. In older adults or old age adults, there is something called as a maxillomandibular advancement surgery. These are all not under my purview. It's all maxillofacial surgeons who do it. So I'm just showing you some slides which the surgeon has shared with me. So I'll be going through that. And distraction osteogenesis is a treatment of choice for severe craniofacial anomalies. Children congenitally born with craniofacial anomalies, and because of that they're landing with breathing difficulty. Then distraction osteogenesis is a treatment of choice. So you disengage the maxilla and then you place the appliance. And that's the key which we use to engage and open the every day. One quarter turn has to be given, and this ensures 0.25 mm of expansion. This is a surgically assisted rapid palatal expansion. The surgery followed with the expansion.
Your video is stuck.
Buffering, sir.
Okay.
Now it's coming.
No, it's quite stuck.
Okay. So basically, they disengage the maxilla from the nasal floor and try to bring open the sutures, the mid-palatine suture, and then we do the expansion. This is how it is being done. The mid-palatine suture is also open and disengaged. Buffering is there, sir?
It's buffering a bit. You can keep talking. I think this is your last video, if I remember right.
Yeah. So we just move the maxilla and then we do the expansion. So maxillomandibular advancement is for bringing both the maxilla and the mandible forward by means of osteotomy. First we do the alignment with the braces, and then we do, this is the genioplasty for the chin advancement. In this maxillomandibular advancement, we get the maximum airway space improvement because we are bringing the mandible forward by about 3 to 5 centimeter. So these are some distraction osteogenesis devices, inside internal devices which we place. So same concept of how we do a maxillary rapid palatal expansion. So the take-home message for today is overjet, deep bite, cross bite, open bite will impact the holistic ENT architecture. Study models are an important tool for assessment of a narrow maxilla. Evidence-based summary reveals a very close interrelation. Functional impact of a narrow maxilla, there are a lot of functional impact because of a narrow maxilla. Hyrax is the most commonly used appliance for expansion of a narrow maxilla. And effects of RME on the nasal floor, it improves the nasal breathing, better oxygen saturation and increased lymphatic circulation. And 6 years of age will be the ideal age to start intervention if the OSA is purely functional in nature. And last but not the least, we always look at benefit, what the child is going to get and what are the risks the child is going to take. If the benefit is going to outweigh the risk, definitely early treatment will always be the treatment of choice. So 3 questions I can ask you regarding the topic. The ideal age to start intervening dental issues or a functional OSA child. Appliance of choice to correct narrow maxilla and posterior crossbite. And what is the mnemonic for the dental findings of OSA?
So I guess all of them can answer you this on the chat box or send it to you once they're done with the presentations. Are you done, Roshan?
Yes, sir. Yeah.
Yeah.
Yeah. We can go to question and answer session. Yep.
Yeah.
It was very nice, Dr. Roshan. In the meantime, we will
Yeah.
give people
I was
answer.
a little time conscious. That was the issue for me. Otherwise,
Beautifully done and well illustrated about a lot of things that are there in the dental situation which we are not even aware of. Okay, so I think without much wastage of time, I think we should go in for the question answer sessions, Q&A. There are a lot of questions that have come in. There are a lot of people who have joined in. At the outset, I just acknowledge a lot of people who are there who have sent in a lot of compliments to all three of you all. Dr. Prakash Munka, Dr. Gaurav from Kolhapur has joined in. Dr. Prakash Munka just finished one OSA workshop and has come here again. Murthy is there, Tushar Ghosh is there. Our very own Dr. Big Kotecha has joined in. It's very wonderful for him to have joined in. He sent me a separate message to say wonderful presentations. Dr. Venus Patel from Surat. Okay, so let me start with the questions. There are plenty. I will go for the questions as they've come in. We'll be very crisp and we'll try to give them the information and then we'll go into more detail because there are a lot of questions here. Okay, so is it mandatory for an ADHD child with altered sleep pattern to be evaluated for OSA? This comes from Dr. Murthy in Chennai. So I'll keep this open to you all. Who wants to
Vijay,
take this?
why don't you take it?
Vijay, I think you should take this one.
Yes, if the ADHD is, as we have seen, ADHD is very commonly associated with sleep apnea, and the child has to be further evaluated with clinical history and examination. If everything is conclusive towards OSA, we would suggest to undergo sleep study.
Dr. Tushar Ghosh from Calcutta is telling Srinivas about nasal endoscopy for diagnosis of OSA, but I think he mentioned that. You already mentioned that, Srinivas. So
Yes.
we'll not take that. Role of prolonged azithromycin in tonsillar hypertrophy.
Yeah,
this again
so
goes
that
to
also,
Vijay.
that also I told. Usually we give it for 12 weeks time, that is 3 months. So 3 months of intermittent therapy or continuous therapy within for 5 cycles. We can wait and watch. Most of the literature says treatment with macrolides, that is azithromycin, or almost equivalent to giving penicillin and equivalent to reducing the recurrent tonsillitis.
That was Dr. Preeti from Belgaum. Now, one of our very own faculties at most of our workshop, very interested in this, our very own Gayatri Moge, Dr. Gayatri Moge. This question, in fact, was in my mind before she put it down. So this question comes to you, with Srinivas, from both me and Gayatri. Would an adenotonsillectomy be recommended in all Pierre-Robinson sequence prophylactically along with the maxillary expansion? So my addition to that question that she's asking was that when you've got syndromic children already with you and you know that you're going to do the bony work anyways, will you still, because the bony work is going to take time, so are you going to still go ahead and do a tonsil adenoidectomy before that?
So, see, these are special children, I've said. These come into the high-risk box. Now, whenever we look at a Pierre-Robin sequence, it is, we will have to evaluate this. It's not correct to remove all kinds of adenotonsils in a Pierre-Robin sequence. We basically need to see if it's really causing an obstruction or is it just the tongue or a skeleton which is causing the obstruction. Because if we see on evaluation and on your cephalograms, if we look at the posterior airway space and it's very less, and on our ENT exam, we do see that the adenoids are not very big, the tonsils are not very big. There is no point in doing an adenotonsillectomy as a prophylaxis for every Pierre-Robin sequence.
Right. So I hope, Gayatri, you got that. Right? Okay, we have another very interesting question from Dr. Venus Patel in Surat. She's asking you, in laryngomalacia, how do you decide which of the child of laryngomalacia requires surgery?
Excellent. So
very good question.
Yes. So there are two kinds of laryngomalacia. Now the laryngomalacia, the ones that are are coming as a congenital cause for stridor. Even in those cases, if there is failure to thrive and if there are apparent life-threatening episodes, only then you operate laryngomalacia kids. Otherwise, you have no business to touch those laryngomalacia kids either, number one. Number two, the ones that I was talking to you all about in the presentation are what are called as state-dependent laryngomalicias. These are kids who are more than 1 year old. That means they don't come into the common bracket of the regular presentation of laryngomalacia. Now, these kids have a lot of daytime symptomatology, and when you do sleep studies, they flag out to be sleep apneics. And when you do a sleep endoscopy, only then these patients actually show the images that I showed you. Otherwise, their larynx, when you do an FLP in the morning, it will be normal. So the theory behind this is neuromuscular, and it's supposed to be more REM related.
Okay, great. This is a similar question that was asked by Dr. Gaurav from Kolhapur, sir. So I hope you got that because his question was pretty much similar, whether treatment for laryngomalacia or tracheomalacia should be conservative or surgical. So that it's almost the same. There's somebody from Brazil who's asked a question, but he's written it in the Brazilian language. So
it's Portuguese. It's Portuguese.
I mean, it's in the Portuguese, so I really don't understand what that means.
We'll probably, yeah, if his name is there, then probably I can write to him.
Yeah, it's Helio Abreu.
Okay, fine. Let me just, yeah, I'll find out and probably I'll write to him.
Okay,
probably
Murthy,
Dinesh can help us.
Murthy from Hyderabad.
Can I add, Simak?
Yeah, please.
His question is, do you use dyes in your residual OSA patient?
Okay, that's the question, is it?
For Srinivas Kishore.
Okay.
Yeah. So, yes.
That was also one of my questions, which I have noted to be spoken in the
yes,
end.
I guess Google Translate.
So I do use dyes in all my residual OSA, irrespective of the age. I mean, Vijay uses dynamic MR, and there is a lot of evidence out there that these two diagnostic modalities have very good pickup rates.
Okay, so again, since it's a preferential thing, if I have a patient, so again, these are questions that I'm putting for the benefit of the audience. So Vijay is using dynamic MRI, you and I might use DICE, or even I might, how do I decide whether I should go in for a DICE post-op, post-TNA, or should I go in for a MRI post-TNA?
Excellent question. So if you are dealing with a syndromic child, or if you're dealing with a craniofacial child, I would definitely go for a dynamic MR. If I'm dealing with a child where the symptoms and signs are not correlating with the findings that I have seen, or the child, the way the parent is actually explaining, then in such case, I would do a dynamic MR. I mean, sorry, a drug-induced sleep endoscopy. But my choice always will be DICE.
You agree with that, Vijay, right? Because I think most of us
actually, the DICE is also as an invasive procedure in syndromic children, where you might find difficult to intubate and ventilate. So a lot of issues are there when we are using DICE, especially in this age group and in this high-risk category people.
So we have one more similar question from Dr. Kotecha from London. He first gives you compliments, so I will go ahead and pass on those compliments. He's taken the trouble. He mentions that he does a lot of partial laser wedge resection of the epiglottis in adults, and asks if there is a similar experience with what we do, whether it's laser or we use coblation or we use RF. Yeah. So, sir, we tend to use what we have. We don't use too much of laser. None of us, most of us in ISA are not really using laser for our work. Yeah, go ahead.
Thank you very much, Dr. Kotecha. Really an honor for you to be here. And I mean, Dr. Kotecha is a direct, he's somebody who's been working with Pringle and Croft, and who are the ones who brought in drug-induced sleep endoscopy. He's got a huge series, and it's a real honor for us, for him to be here. we use supraglottoplasties in pediatric, Dr. Kotecha, and we seem to be getting pretty good results with our residual OSAs or occult laryngomalacia cases.
Okay, so that's what a big thank you for him to be here. We will interact with him again on personal levels. There is a question from Dr. Suninderjeet Singh in Amritsar. Can maxillary expansion be achieved after 18 years? I think I'll let Roshan take that.
Yeah, absolutely.
Yeah. So after 18 years, maxillary expansion will not be possible. We cannot expand the maxilla. We'll only get the tipping of the teeth, which can happen because the sutures are all completely closed. So in this situation, you can think about surgically assisted rapid palatal expansion, where we open the sutures with the surgery and then we place the maxillary expansion device, and this will help very well in correcting the crossbite and to expand the maxillas.
Great. I'll let you take this question again, Roshan, from Murthy again at Hyderabad. What is the youngest age for distraction osteogenesis for syndromic children with associated stridor?
And this we can, depending upon the anomaly and depending upon what type of distraction osteogenesis we are going to use, and maybe for a mandible, we can start from 3 years. If it's 3 to 4 years, we can think about a distraction osteogenesis.
But you know,
for a mandible.
Yeah, Murthy, if I may just add to that, if the child has stridor, you definitely need to scope the child and figure out where the stridor is, and probably before the osteogenesis, distraction osteogenesis starts, we may have to do something about the stridor ourselves in that. Okay, Dr. Balakrishna Ramaswamy from Manipal. Common cause of post-TNA residual mouth breathing is habituation and recurrent adenoid hypertrophy. How do you prevent the recurrence in adenoid hypertrophy? And what is the role of coblation? We can leave aside. And how would you prevent nasopharyngeal stenosis?
So there are 2 points to that, 2 answers to that question. I think the first thing is that he spoke about how do you prevent adenoids from recurring. So if you look at the kind of patients who would present with recurrence, they come in 2 kinds. One is the ones on whom you had to do an adenoidectomy at a very young age. Supposing you have done an adenoidectomy at 1 year, 2 years of age, the natural pattern of lymphoid tissue in the body is to grow, especially adenoids grow up to age 5, 6. So if you were forced to do an adenoidectomy in this child at age 3, there is a chance for this child to have adenoid hypertrophy again. So you can take care of it by doing a sort of a complete job with whatever tool that you have in your hand. Number 2, try to rule out if there are comorbidities. 2 commonest comorbidities that can cause adenoid to regrow are 1, allergy, 2, laryngopharyngeal reflux. So if these 2 things are as comorbidities have to be taken care of, I think you will have no problem in taking care of that adenoid hypertrophy. What was the second part of the question, Seema?
About nasopharyngeal stenosis.
Nasopharyngeal stenosis.
Yes. So nasopharyngeal stenosis again depends on the surgeon. If you are very aggressive in using hot techniques when we do surgery, and also I've shown in the expansion that I've done in kids, I do not use I'm a huge advocate of radiofrequency and coblation, but I do not use that because I have seen a bunch of kids presenting with nasopharyngeal stenosis when regular monopolar has been used. I would urge you to exercise caution when you are dealing with kids, especially kids with small mouths, with difficult mouth openings, when you are forced to do adenotonsillectomies in kids who are less than 2 years of age.
Right. So just for the sake of acknowledging, I will acknowledge Dr. Dipesh Prajapati from Jaipur, who is a pediatric dentist. He's complimenting all of you all, and he would like to be in touch with more people with airway related issues in ENT. Thank you.
Thank you.
Okay, so I am just scrolling through and picking up some of the ones which we really need right now. Role of tongue tie in pediatric sleep disordered breathing. Dr. Dhanraj from Chennai. Vijay?
No.
I think Dr. Roshan can explain about the tongue
Tongue
thrust.
tie. Go ahead, Roshan.
Yeah, tongue tie surgeries actually is now in the, because we start, infant tongue tie has been talked a lot. Immediately after birth, if there is any feeding difficulties and all those things, we start in infancy itself, tongue tie is being done. Okay, so if there is functional problems for the child a lot, so we do the tongue tie as early as possible. Okay, we don't wait, because the earlier we do, the earlier you get good speech articulation. Otherwise, again, the same problem like mouth breathing, the brain is got tuned to pronounce certain syllables in a certain fashion. So again, if you do the tongue tie at a later age, it's going to be difficult for the child to reprogram in all these speech issues. Okay, and that is one of the reasons we address to the tongue tie as early as possible now. So infancy tongue tie has been a recently it's been newborns itself we do a tongue tie procedure. If there is problem in feeding and all those things. But pertaining to OSA, again, OSA we are looking at an age group from 6 years. Okay, evaluation starts from the age of 6 or 5. We are looking at. So if there is some issue in the tongue tie and along with the OSA issue, dental finding, definitely we can do the surgery also along with that.
Dr. Roshan, I want you to take this next question also. This is also from a very regular colleague of ours, Dr. Kavita Chaudhary from Pune. She wants to ask you, how long does it take to approximately achieve the expected expansion by rapid maxillary expansion?
Sir, we usually take a study model first and we measure the transverse dimension from the intermolar distance. So that is comparing with the upper teeth to the lower teeth we assess, and if it is deficient, and then we are looking at how much of deficiency is there, and based on that, excess of about always 2 to 3 mm we expand. Suppose the deficiency is going to be 3 mm, we are looking at expansion of about 5 mm. Okay, so for 5, come again with the question, sir. The duration of the appliance.
Yeah, how long do you think it takes for the complete expansion to be complete, where you say this is end of treatment now?
Rapid expansion immediately happens. Suppose 5 mm of expansion I'm looking at. So I'm going to do 0.25 mm expansion per day. So the expansion process is, the entire active expansion process is going to take only 20 days. Within that time, the expansion is going to happen. But after the expansion, we don't remove the appliance immediately. So that is the key. Because the sutures are opened, we want bone formation to happen in the suture opened area. So the bone formation to happen and the complete remodeling takes another 3 to 4 months. So till the time this appliance has to be in place. And after we remove, there is every other possibility for the extraoral oromuscular force to put pressure on the jaw and constrict the jaw a little bit. To prevent that, we give the retention appliance, which is called the transpalatal arch, which has to be there in place for at least another 2 years. So that is how the entire protocol goes by.
Great. Dinesh from Tech Team, please tell me when we are just last 5 minutes, because I have 2 of my very important questions to the end before I summarize. So right now I'm just taking the questions that are coming from the audiences.
Sir, you can take as many as time.
Great. Thank you. Thank you very much for that. So now there are a lot of questions. They are pertaining to palatal work in children, okay, which we have not, I mean, Srinivas has spoken about the expansion. So there's Dr. Manish Mandra from Chandrapur in Maharashtra. There's also Dr. Palyanappan from Trichy who's joined us. Thank you, sir, for coming on. And Dr. Yogesh Singhal from Modi Nagar. Most of these questions are related to the fact, and this I'll leave to both Vijay and Kishore. Is there really a role of zeta palatoplasty in children, or is it contraindicated? That's one part of the questions that have come in, and the other parts are related to lateral pharyngeal wall collapse management in children.
Yeah, I'll take up the first question by Dr. Manish. I would say personally not done a zeta palatoplasty in the children, as it is a very aggressive procedure, and it can very much can cause nasal regurgitation and velopharyngeal incompetence. And about the lateral pharyngeal collapse, I think Kishore showed a beautiful video of expansion sphincter. Kishore, can you comment on that?
Yeah. So when it comes to lateral collapse, the decision making should be basically either on dynamic MRI or DICE. Once you made a decision on DICE that lateral wall is the cause for it, you need to be conservative as to what you do. There is a lot of evidence out there about the utility of expansion sphincter pharyngoplasty. Even though Barb is the new kid on the block, there are very, very few studies out there showing the efficacy of Barb repositioning pharyngoplasty in kids. However, if there is any procedure that is the most conservative in the field of palatal surgery today, it is Barb. So I think it's about time that Barb makes an entry into conservative palatal procedures in residual pediatric OSA.
I mean, otherwise also BARD is like really only reason why probably it becomes major, and this is the tonsillectomy that is done before. Otherwise, it's really kind of, it's one of the best ways to expand the lateral wall up to the level of the pterygomandibular raphe. Anyway, we'll not get into that. There is a question from Dr. Mudit Mishra in Bareilly. Post tonsil adenoidectomy, is it really mandatory to get a post-op PSG done? Because if the patient, attendant and the relatives are all satisfied, would you really go ahead and do a PSG?
Sir, I would like to tell you at this point that, see, every case of pediatric Hello? Can you hear me?
Yes, sir, I can hear you.
Yeah. Okay. So, not every case of adenotonsillectomy requires post-op. If the patient is asymptomatic, if the parents are happy, the child is not remained a mouth breather, the child's whatever concerns are by the parents have been answered, then that's fine. It's only cases who remain to be significant in terms of their symptoms, or if you're dealing with a syndromic or an obese or a special child, maybe a sickle cell anemia child, only then you need to look into it a little deeper.
Okay, there's lots of compliments coming from Dr. Dharmesh Bhutti from Resort. And again, Dr. Gaurav Tushar Ghosh has said hi to you all. Okay, there is one question here which I lost my. Okay, let me ask you my question now to one of you guys before I refresh and see what other questions come through. Okay, so this is now something that I want to ask all of you all. If I have a patient whom I have kind of assessed, and we are assessing now all this entire discussion, right? The entire discussion that we've had is related to residual OSA in a pediatric age group, and we have now discussed in detail all the possible causes that would have related to the residual OSA that remained. Right? So with this background in mind, what should be my protocol in the very first time so that I do not have a residual OSA? Right? So now that we know the background, that we've got obesity related issues, we've got craniofacial related issues, we've got so many other issues. So what should I be doing right the first time to prevent residual OSA?
See, basically, you have to look into just not looking into the oral cavity and oropharynx to see adenotonsillar hypertrophy and operate on them. You find out what could be the other reason and other causes and classify them according to type 1 and type 2, type 3. As we all know, type 1 has very good success rate of about 90-95% of following adenotonsillectomy. So if you can identify them and choose the high-risk patients and counsel the parents about the outcome and follow them up, not just doing adenotonsillectomy and leaving them, that's not the idea. So proper counseling before taking the patient for surgery and getting opinion from colleagues, periodontists, where the child may need further, as he rightly said, most of the child will be having an open bite, cross bite, all those hypoplastic maxilla and the dental alveoli because of long-term mouth breathing. So all myofunction therapy, everything plays a role. It is a holistic approach. It's not just adenotonsillectomy. The adenotonsillectomy is not the only one. After that, that is the first step of preventing adolescent and adult OSA. So after that, there are so many steps. We need an anti-allergic medication with intranasal steroidal spray or a montelukast. So every part of this protocol plays a role in preventing and preventing a residual OSA.
Srinivas, you want to add something to that?
Yeah, I think.
So I would like to add one more thing.
Yeah, please, Roshan.
The main counseling is the key in management, sir. It's a holistic approach we need to do. And two more specialty people also play a very good role. One is the sleep physician, okay? And apart from that, the occupational therapist also will have to be in the team to do a proper assessment from their perspective before you go ahead with all the ENT surgeries. And of course, a urologist also has to be there. Okay, because OSA sometimes has some urological issues, not only neurosis also is there. So this is all teamwork which has to be taken into place. Yes, sir.
Yeah. So see, basically, what we've sort of taken this whole thing approach from a pediatric OSA into completely residual. I think we should just put some breaks at this point. Go back a little bit. It's they're by ASM, by AOHNS, by American Academy of Pediatrics, the gold standard for management of pediatric obstructive sleep apnea even today is adenotonsillectomy. Having said that, that doesn't mean every case will get cured by the adenotonsillectomy. I think we just have to zoom out a little bit, look outside the box, look at the BMI, look at the skull, and then proceed. And as Dr. Roshan said, counsel and bring in the relevant specialties who are applicable to that particular case and scenario.
Yes.
I guess that should be the biggest take-home message on this particular point, because there were questions to this effect again from Dr. Venus Patel in Surat, where the counseling, I think the take-home message is exactly that, because this is where the incidence of residual OSA would become much lesser, because if you counseled and said that there is a second stage that is needed at the end of a tonsil adenoid, then automatically the results do not go into a failure of tonsil and adenoid. So I guess proper counseling is the take-home message that is very important here. Vijay, how do you decide for use of CPAP in children? I mean, which are the cases that you would consider using a CPAP in the child?
As I told you, those who are not willing for surgery or who are contraindicated for surgery, or those who are not having an anatomical level of obstruction, like pediatric OSA in a patient with primary pulmonary hypertension. So, and syndromic children where the multi-level surgery may be complicated or more morbid. So in those situations, applying CPAP will be very easy and helpful to the kid. That's a main indication.
Perfect. Great. So I think covered most of them. I just have one last from my end, a very simple practical point that I would like to ask in now. That is that the fact that we've now decided that it's either a type 2 or type 3. And by the way, Vijay, that was a fantastic description of the types of obesity and types of OSA in pediatrics. I think you should put up that slide again before we end. That was a very good one. So what I was trying to ask is, now you've decided you've got a child, he's got other issues besides tonsil and adenoids. And you know that, okay, obesity you're going to deal with our dental colleagues, or you're going to deal with some maybe lingual tonsils at a later date. Now, pre-operatively, when would you consider doing a DICE in this patient in this stage, Or would you rather wait for TNA to get over, wait for the residue, and then do a DICE at that stage and then take it further? So would your DICE be... Yeah, go ahead.
I would prefer to do the DICE if there is any residual after clearing the anatomical static obstruction. Because DICE is the one which we are looking for the dynamic obstruction. So which has to be assessed after the removal of static obstruction, especially in pediatric age group. I think Kishore is doing more pediatric DICE, and what is your opinion, Kishore?
Go ahead, Srinivas.
So, to me, if I have a child who's slightly on the obese side, who's a teenager, 15, 16, like I showed, and he's on the borderline for pure adenotonsil hypertrophy, anyway, we are giving anesthesia before a surgery. I would do a DICE on this child before we go ahead and do the adenotonsillectomy. Talk to the parents that, look, we've removed the first layer, and as you correctly said, probably lay the path for further management, saying that, okay, based on this DICE, this child might require further management, or how obesity control may be very pivotal for this patient. So that this document of DICE that we have done will actually be very visual for the parents to actually get themselves involved and take part in this journey of managing this patient.
Yeah. So my point.
Okay. But yeah, still, this DICE is being done in the presence of adenotonsil. So that adds on to the static factor.
Yes, very true, Vijay. So that's why we don't do multi-level surgery at this point.
Okay.
No, so if like what we are discussing now, if we were to do a pediatric DICE as a one-time procedure, as a one procedure, so now what is going to happen is you're going to have to do pediatric DICE before and after, right? So if you are to do pediatric DICE at one time, then when does it make more sense to do it before the TNA or to do it after TNA?
That depends on the child that you're taking. The phenotype of the OSA of this child. Is it, as Vijay put it, is it type 1, type 2, type 3? Yeah. If it's a type 1 phenotype, I don't think we have to even consider. It's only for the type 2 and type 3.
Beautifully put. That's the take-home message that has to really go out to the crowd now. So I think we've covered most of the questions. There's just one last question on refreshing that has come in, which is about, this is from Dr. Palyanappan, again from Trichy. Nasopharyngeal stenosis, just a quick outline on the management.
Okay, so let me quickly take this. So nasopharyngeal stenosis happens because of abnormal use of either laser or monopolar diathermy at the level of the velopharyngeal sphincter. If you expose a lot of mucosa there, so if by mistake you happen to do that, it's very important that you can, so at the primary level, you can inject some Kenacort in that area, try to help to prevent any coagulum formation. But if it does happen, unfortunately, the best way is to actually do a Zeta for nasopharyngeal stenosis and put nasopharyngeal airways as stents for at least 6 weeks. And that will take care of the nasopharyngeal stenosis in a nutshell. It's not that easy.
I'll take this comment once again from Dr. Kotecha, and this comes from my regular interaction with him with regard to dynamic MRI. So he's put it specifically, it's a comment, not a question. DICE allows visualization of upper airway, which is very useful, but the dynamic MRI adds to the holistic picture as it emphasizes the extrinsic push from the outside, whereas DICE will give you only an insight into the intrinsic airway. Thank you, Dr. Kotecha, for that, because this is what we've always been talking on. Okay, Dr. Kavita again from Pune wants to know how often do you see LPR in pediatric age group?
I'll take that. It's very common. In fact, LPR and OSA are very closely related comorbidities, one complementing the other, because the tremendous amount of negative pressure at the level of the pharynx causes the reflux to come up. And that causes your lingual tonsils, your palatal tonsils, and your adenoids to hypertrophy. So it's very, and also it is known that in kids, the upper esophageal sphincter muscle tone is a little low. So it's very common for kids to have reflux, needs to be treated. And it's just not the acid which is important, it is the pepsin that comes with it.
Dr. Prakash Munga again is asking pretty much on the same lines, velopharyngeal incompetence after adenoidectomy and palate procedures. You want to take that? Kishore?
Vijay, why don't you take it?
Vijay, go ahead.
I didn't listen to the question. Could you please repeat?
Prakash Munga wants to know what is the incidence, or rather what do you do for velopharyngeal incompetence after adenoidectomy, if you get any?
No, I never had any patient touch wood. But first thing is to palpate for the submucosal cleft palate before doing an adenoidectomy. And if you feel that if there is any submucosal cleft palate, avoid it. So that I think answers.
And I think Vijay made a very pertinent point somewhere in the talk. I don't remember well, but it's very important what Vijay said about scoping the child prior to anesthesia. It may not necessarily be DICE, because there's a lot of adductor palsies that are coming in, and you may lose that as a cause of snoring. And there have been patients who've been difficult to intubate at those times. So I think we have covered almost all the questions. I think I will let this last question again go back to Roshan. Do you think a frenectomy will help in treatment or OSA in children? If there is a...
No, sir. Frenectomy may not be helpful for OSA in children. Maybe if there is a high fill attachment, maybe it will help a little bit for the lip seal to happen, improve the lip seal if there is a short upper lip. But if there is a proper OSA, definitely frenectomy may not be helpful, sir.
Okay, great. And just on a lighter note, why is it called a hygienic one? Do you have something which is unhygienic also? Expander?
He's talking about the name of the expander, Hyrax.
Okay, anyway, so thank you.
The main lot of appliances are too more cumbersome than this, what you see. So that is why compared to those kind of appliances, these are called hygienic rapid expanders. They are too more cumbersome, too bigger in size. Okay. So this is comparatively smaller in size to those appliances.
Yeah,
and the maintenance is quite easy.
I think oral cavity and hygiene are just opposite.
Okay, so
there are a lot more answers have come for his 3 questions.
Yeah, that is, I saw on that, so I think that we'll email
just
it.
Pass a comment on
lots
that
of
and conclude.
Okay, so I'm going to sum this up. Thank you very much, all of y'all. I mean, all 3 have done real great justice, and I'm really hopeful that a lot of the ENTs would have now got their eyes opened that pediatric OSA is not just simple tonsil adenoidectomy where you get away with it. And Vijay has very beautifully brought out, few of the very important points where, genetics is being overlooked. There's a lot of genetics that is now coming into the picture of OSA in general, and of course a lot in pediatric OSA. He brought out the incidents very beautifully and the 3 types of OSA. So even if there's no time for you to bring up that slide again, Vijay, please make it a point to send it across to all our viewers. That's a very wonderful way of looking at it. Many people do not realize the different types of pediatric OSA that are still there. And very beautifully, he has explained to you with regards to the major and minor criteria which will actually decide what and how you're going to treat the pediatric OSA with the algorithms as to what patients you're going to really have to plan your future residual OSA management, how you're going to evaluate them even more thoroughly, bring in a lot of people from the physician side, the endocrine side, the dental side, and then you start evaluating and then you start going ahead and treating them. So that was beautifully outlined by Vijay. Srinivas again did a fantastic thing about enumerating the entire kind of problems that you can have, be it syndromic, be it related to the bony box, be it related to weight reduction in itself, creating so many improvements. And the fact that he's one of the few who's doing expansion cases in pediatrics in residual OSA. So we don't end right there at just a pediatric tonsil adenoid. You reassess again. You reassess with either a dynamic MRI dynamic MRI is a really good tool even in children, like Vijay has very clearly said, also in terms of those that are not fit for anesthesia, those that may not be willing for anesthesia, or those that are, high risk cases for that. So you look into that. And Srinivas then went ahead and spoke about the use of CPAP in children. CPAP in children and myofunctional, which has a major role that can come. So he elaborated on that. These are things that you need to really look into, because these are where you need to treat the residual OSA with. He went ahead, Srinivas went ahead and spoke in detail with the role of the nasal steroids, the medical management of the residual OSA, because a lot of residual OSA and the allergies and stuff is not treated, or the simple medical management is not looked into, you may continue to have that residual OSA, which is very easily treatable. And he beautifully, laid down the table for Roshan to, bring out the fact that it doesn't end with just the soft tissue work that we as ENT surgeons do. And then Roshan very beautifully elaborated to us the various kinds of, the issues that are there with the bony box, with the maxilla, with the dentition, with the suture lines, with their expansion, the way they are to be expanded, the age, which one of the take home messages very good is that you do this as early as you can. You do not wait like what we used to wait once upon a time till the age of 8 years and 10 years. You've got to attack pediatric OSA as aggressively as possible, as early as possible. So he went ahead and then beautifully showed the different modalities and the way that you can expand them. And we need to really understand that our other colleagues have a major role to play in pediatric OSA also. So in short, it should be a take-home message where we are able to understand that it's a multidisciplinary approach, not only in adults, but in pediatrics. And in pediatrics, there is a major role of people like Roshan, Gayatri, Sukhwinder, all these people to actually come in into our domains and start treating a lot of patients here. So I think we have crossed a lot of time, and I would end at that with a very big thank you once again to to Mr. Sahai, Mr. Mahindra, Mr. Janeja, and the divisions of Some Pharma who have come out, and to all of you viewers. I'm told there's a huge audience out there, upwards of 800 plus is what I last refreshed. So it must have been much more. And thank you for all those from outside the country, from Brazil, Dr. Big Kotecha from UK, and all our colleagues across the country for sparing your time. And I would just hand over to them. Any last words from the speakers? Please go ahead and
make a
you
small
yourself hand it
announcement?
over to Mr. Sahai.
Can I make a small announcement?
Yes, please. And I think go ahead and hand it over to Mr. Sahai at the end of it all.
Yeah. So all these videos of our presentations are available in our website, iassa.in. Those who wants to become a member, please log in and send their membership form. And coming Tuesday on 12th May, 10 a.m. to 12 noon, we have interesting topics on palatal surgery. And the coming Friday, 15th May, 10 to 12 noon, there are 3 international speakers: Professor Clemens Heitzer from Germany, Professor Peter Baptista from Spain, and Professor Robson Capso from Stanford University, USA, going to talk on recent advances on OSAS. Don't miss it. Please log in to www.entclassroom.com. Thank you, Sun Pharma Pharmacare Division, for this wonderful.
I think our president, Dr. Sagar, wants to make a last final parting comment. Sagar, please come on stage and hand it over to.
Thank you, Seema, for that. I was about to say that the time is going to be the usual routine on Tuesday, that is 10 o'clock, and not the evening. So please, delegates, log in at 10 o'clock in the morning. We have wide range of international faculties coming on. So please join us. Thank you once again, everyone, especially Sun Pharma for partnering with us.
Over to you, Mr. Sahai. Yeah. Thank you very much, everyone. Thank you, Vijay, Srinivas, Roshan. Thank you very much.
Thank you, sir. Thank you very much. Thanks for the opportunity.
So thank you, one and all. In fact, before we conclude today's webinar, let me convey my heartiest thanks to all my distinguished speakers. As a matter of fact, from across the country, we are getting lots and lots of feedback, and the entire series of ISA Classroom is becoming extremely interesting, informative, setting new protocols for the thousands of clinicians across our country. Thanks a lot, Dr. Vijaya Krishnan. Thanks a lot, Dr. Srinivas Kishore. Thanks a lot, Dr. Roshan. And above all, thanks a lot, Dr. Seema Sheikh, for beautifully moderating the session. And of course, thanks to the digital team for making the audio and visuals so impactful, flawless. And we are indeed very, very thankful for all the delegates for sparing their valuable time this evening. And sir, Dr. Seema, there are 1,000 viewers right now.
Wonderful, wonderful. I'm very glad. And a very big thank you to Dr. Naveen Patel. I was not able to see him on the screen, but sir, thank you for staying on with us all the time. You are one of our pediatric OSA man.
It's a brainchild of Dr. Naveen Patel, who has actually created everything. He had been instrumental in bringing all of us on this platform. Thank you very much.
Thank you, sir. Thank you. Big thank you from all of us in unison.
It's a thank you to everyone, especially to the whole Sun Pharma team. They're putting a big effort in making this realized to the dream of all of us. Thank you very much.
Thank you. So with this, we conclude today's series 6 of our ISA webinar.
Thank you.